So what do the guidelines tell us about tricuspid regurgitation? Well, the answer is not very much. We say that the only class 1 indication for addressing the tricuspid valve is if you have severe TR at the time of a left-sided operation, you would fix it. Not really any data to support that. It's just common sense that if you're operating on a patient for severe left-sided disease, that you wouldn't leave severe tricuspid regurgitation behind at the time of surgery. The two kinds, primary and secondary. Primary TR suggests that there's something wrong with the valve itself. This is usually either endocarditis from drug addiction, carcinoid syndrome, or trauma. Most TR is secondary. It's secondary to disease on the left side of the heart or secondary to disease in the lungs that causes overload on the RV and subsequent RV dilatation and TR. We have a little data about primary TR not due to drug addiction, which would have its own impact on prognosis, and not due to carcinoid, which also would construe how you interpreted prognosis. 60 patients from the Mayo Clinic of traumatic TR and what that led to. So severe traumatic TR had an impact on prognosis, looking at normal population versus the presence of severe tricuspid regurgitation. It clearly worsened overall outcome. And of that 60 patients, 26 were initially asymptomatic. And if you look at what happened to them over time, they progressively developed difficulty, whether atrial fibrillation or heart failure or the need for surgery or death. Clearly, the presence of severe primary TR impacted prognosis in a very negative way. This is what's troubling. This is an article in JACC that has not been published yet, but looking at a survey of the country, of the U.S. in terms of the outcome of primary TR surgery, the operative risk was 9%, which seems extraordinary when you think that the normal risk for an aortic valve replacement is 1 or 2%, and for a mitral valve repair is about 1%. The operation for TR alone, without doing anything to the left side of the heart, had a very, very high mortality. I think we're just beginning to try to understand why that would be. But as I say, most TR is secondary, not primary. And the outcome there is also worrisome. This study by Nath and colleagues looking at survival, the presence of secondary TR, the more TR you have, the worse your prognosis. The question is this chicken or egg? Is the secondary TR there because the left side is so sick? Or does the TR itself have an impact on prognosis? So they tried to divorce the two, first looking at the presence or absence of pulmonary hypertension. So in the top are patients with pulmonary hypertension, and the worse, the more severe the TR was, the worse the prognosis was. But even in patients without pulmonary hypertension, worsening secondary TR impacted prognosis. Trying to segregate the patients according to left-sided ejection fraction. Reduced EF on top, normal EF on the bottom, even in patients with normal left-sided ejection fraction, the presence of severe secondary TR impacted prognosis, which is very worrisome. So then what should we do with secondary TR at the time of a left-sided operation? We know that the course of untreated mitral TR after mitral valve surgery is somewhat unpredictable. In this study from Japan, initially the TR gets better after you fix MR, but over time, if you don't do anything to the valve, it worsens again. Now, it's not surprising that if we fix TR at the time of surgery, you fix it. So there are plenty of data for that. Looking at this study by Californian colleagues, here's where the tricuspid valve was left untouched during left-sided surgery. Here's what happens when the tricuspid valve was repaired. It made a big difference in the amount of postoperative TR the patients have. In this study from David Adams' group, looking at the freedom from moderate TR, if you did only a mitral valve operation alone, the patients had more TR than if you did a mitral and a tricuspid operation. Makes a lot of sense. In this more recent study by Takano and colleagues, when they looked at their operative experience during their early operative time when they weren't addressing the tricuspid valve versus later when they were repairing the tricuspid valve, guess what? There was less TR, not very surprisingly. This data from the Mayo Clinic, one group that has sort of challenged that, and the Mayo surgeons are not convinced that they need to address every case of moderate TR at the time of left-sided surgery. What you're looking at, especially here, are the black bars and what happened to moderate TR over time. They didn't find much of an increase in moderate TR over time, and they've made the argument that not necessarily does every tricuspid valve need to be addressed. So there's some controversy. Most surgeons, I believe, think that fixing TR fixes TR. The question is, what impact? Oh, first of all, why should it get worse? You're fixing the left side. Why wouldn't TR always get better? I think it may be a volume overload. If we successfully correct aortic stenosis, or we successfully correct mitral regurgitation, all that new cardiac output is now going forward. And in one stroke, it comes around to the tricuspid valve, where it may actually volume over. The right ventricle has been taking it easy. It hasn't had much cardiac output to pump because the left side was sick. Now we made the left side better. And that may impact a volume overload on the right side. I'd like to try to prove that, by the way. That's just an idea. But what does repairing the tricuspid valve do for outcome? We know it'll reduce the amount of TR the patients have. But what's the next step? Well, in this study from Canada, if you look at patients without severe preoperative tricuspid regurgitation, those patients who had more than 2+ TR that got repaired and more than 2+ TR that didn't get repaired, there wasn't any difference in long-term survival. A study from the Cleveland Clinic of about 160 patients, there didn't seem to be any difference in overall outcome, whether or not the surgeons repaired the tricuspid valve at the time of left-sided surgery. This study from Californian colleagues suggested the opposite. Looking at survival was definitely better if the tricuspid valve was addressed at the time of left-sided surgery, and there was less heart failure as well. So, and obviously, none of this represents a randomized trial, which, by the way, the CTSNet is engaging a randomized trial now of what to do with tricuspid regurgitation at the time of left-sided surgery, because the field is so confusing. With the interest of trying to clip the mitral valve, it's been extended, at least in case studies, and in this experimental study, to the tricuspid valve. And in this pig model of TR, a whole variety of different clipping strategies was employed, 1 clip, 2 clips. Cardiac output increased the most with this strategy of clipping the anterior and posterior leaflet to the septal leaflet in that fashion. Whether or not that would bear out in humans is hard to say, but this recently published article using the tri-align system, which is a clip and suture system that reduces TR percutaneously. This is now in people. At 30 days, there was a substantial improvement in New York Heart Association classification, a substantial improvement in quality of living, and a significant improvement in 6-minute walk. Obviously, there was a reduction in the amount of TR the patients had. So that's, this is going to evolve, I think, pretty quickly, especially with the worrisome results that surgery for primary TR carries a high mortality. So secondary TR is bad for you. I think it independently worsens prognosis. The question that remains is whether or not fixing it improves prognosis. I think that, there's no question that if we address it at the time of left-sided surgery, you'll improve TR. It may reduce the risk of heart failure. I'd say that its effect on overall mortality at this time is uncertain. I think there's a rapidly developing consensus among surgeons, though, not to leave it. And some surgeons are even operating, even doing a tricuspid annuloplasty for very large tricuspid annuluses, even if there's no TR. I can tell you as a cardiologist, I hate it when somebody's gone to the operating room, had a wonderful left-sided operation with everything perfect, and the guy comes back to me with a pulsatile liver and bounding neck veins. And I would have to say that for the guy that gets left holding the bag, I prefer that the tricuspid valve is approached at the time of left-sided surgery. But I think percutaneous devices, again, this will be an area of exploration. That tri-align system, if it holds up, and that was only 30-day results, might be a very encouraging way of treating at least secondary tricuspid regurgitation. Thank you very much for your attention.